I picked this topic. It's point-of-care ultrasound. I actually get to know it during my last year of residency, and since then I have been trying to learn it more and more, and I really found it very useful in my daily practice. So I really want to share some of this experience with you guys and trying to get you some of the clinical usage of point-of-care ultrasound. I think it's an evolving area of internal medicine. So my goals for this presentation today, so hopefully by the end of the presentation, you'll be able to name the clinical application of point-of-care ultrasound in a different clinical setting, inpatient, outpatient, general internal medicine, subspecialties, and then hopefully you'll be able to understand the pros and cons associated with the use of point-of-care ultrasound, and be able to recognize and know some of the resources available for you if you get interested and you want to learn more about it. So I have no any financial disclosure. I have no any relationship with any of the ultrasound companies. So and also, just for the record, this POCUS has nothing to do with this Disneyland movie. I just found it during my work and search for the presentation. I even don't know what the movie is all about. So, so this is my milestone. I'm gonna talk about what is POCUS and the kind of background and a little bit brief history, and then why it's possibly useful for general internists or hospitalists and subspecialists. And also, we're going to go into the clinical applications and then talk about some of the challenges that might be associated with it. So just a little bit of background. I really couldn't find any a universal definition of point-of-care ultrasound, but generally it can be defined as the use of portable ultrasound at the bedside to assist a provider in clinical decision and or bedside procedures. Basically, instead of sending the patient to the ultrasound suite to get some studies done, you get the ultrasound to the patient at the bedside. And I think one of the most important part of the definition is that it's actually the most important use for POCUS, I believe, is really to get an answer to a clinical challenge that you have during the patient encounter, specific clinical questions that you get some answer for, and you can use point-of-care ultrasound for that. As you probably know, I think probably it was first used in the emergency room. ED physicians are much more experienced than us internists in point-of-care ultrasound. Probably started with the FAST exam, which stands for the focused treatment with sonography for trauma. It was mainly used to kind of detect bleeding and fluid associated with trauma patients. And then it started to evolve gradually, and other specialties started to get in. And actually in 2001, the AMA stated that its ultrasound has diverse applications and is used by a wide range of physicians and disciplines. So they started to recognize it's not just for emergency room and ICU. And then in 2004, the American Institute of Ultrasound and Medicine recognized that actually the concept of ultrasound stethoscope is rapidly moving from the theoretical to reality. I mean, we're not there yet, but since that time, they started to recognize it actually can be more widely used than it was at that time. So generally, it moved from emergency ICU to use of general practice in internal medicine and even in pediatrics. So why point-of-care ultrasound? I mean, this is probably one of the most important slides in the presentation. I really don't see point-of-care ultrasound as a substitute for a good physical examination. I'm one of the big fans of physical exam and bedside manners, and I think this is really key, that point-of-care ultrasound is not really to replace bedside assessment, a good bedside assessment, HMP. And at the same time, it's not really a replacement for a formal ultrasound study if you need it. It's basically the major goal of point-of-care ultrasound is to kind of close the gap between your clinical assessment, between your bedside assessment, physical exam, and then the use of imaging if needed. So it's can give you quicker answers after your basic assessment. But again, it's not a replacement, it's a supplement. So the major advantages, as I see it, is number one, of course, it's very safe, much safer than CT scan, MRI. It's non-invasive, no radiation involved, no contrast. You don't have to worry about allergies and AKIs and if the patient has pacemakers, it's all fine. So that's really a major one. And then it's rapid if you have the device, especially if you have one of the handheld devices or the pocket devices that we have in CRMC and the VA. You can just get some answers like in a few minutes. And as I will see here, in a lot of these studies, actually the time took by the physicians to do an ultrasound exam is not that much. And then, of course, if you already have the device and you're able to get one, maybe by doing more billing or maybe by provision of your department, it's actually very cheap, especially for the patient, right? Because you just get a lot of information by doing the exam without sending the patient to any radiology for imaging, depending on the clinical scenario, of course. And then one of the things that I really like about the POCUS is actually brings us back to the bedside. There has been a lot of talk about us being deviated from the, clinical encounter with patient, especially after the development of the electronic health records. People talk about physicians spending more time in front of screens instead of in front of people. So having the ultrasound, you gotta stay with the patient for a few minutes, talk to the patient, maybe get more history, build more rapport with the patient. I think that's really key. And I think probably it's an area for, scholarly work. So I really invite the resident, if anyone interested, I think we can study how much the patient perceives the bedside ultrasound. Does it increase their satisfaction? Does it increase their, convenience? So it's really, I think I don't think it has been studied that much. So it's an area of scholarly work, I believe. And also it's kind of reliable. It's really, as I said, it's better than, in a lot of aspects, better than physical exam, but of course, sometimes it falls inferior to the imaging, although in a lot of clinical scenarios that we'll see, it's actually better than some of the imaging studies that we traditionally do. So it has generally very good sensitivity and specificity. And then relatively it's easy to learn. A lot of these studies done, actually, a lot of them have been done by physicians who didn't have years and years of experience. Of course, some of the study has been done by experienced physicians, but not all of them. So you don't need a lot of training. But of course, ultrasound, they say it's operator dependent. So the more you do it, the better you get at it. So in the next slide, I'm going to maybe focus on this last issue that it's actually not very difficult to learn. So for our medical resident here, I found this study, which is actually very interesting. The question was whether the point-of-care ultrasound can make any difference in admitting diagnosis when it's done by medical residents who have quote-unquote limited ultrasound experience. And I'll talk about what limited is. It was published in 2015. And basically what they did is, it's done in Norway. A lot of ultrasound studies actually have been done in Europe. So they have 12 residents, all of them trained in point-of-care ultrasound. And the training was only a workshop, and then they supervise them doing a lot of images. And then they have to do a lot of their own images afterwards. So they randomized 6 of these 12 residents to use point-of-care ultrasound when they're admitting patient in the inpatient service. So they do their HMP, they made their diagnosis, and then they do point-of-care ultrasound and see if the point-of-care ultrasound made any difference in their initial assessment based on their history and physical exam without the ultrasound. They focus on cardiac exam and abdominal exam, and the average time taken by the resident in general was 5 minutes for each system. So overall, it took them about 10 minutes to finish the whole exam. So what they found is among the 199 patients who were admitted, 69 of them, which is about 35%, actually the diagnosis was either changed, verified, or added. So in 35% of the patients admitted, there's some change made because of the point-of-care ultrasound. And I put some examples here, which is actually very, it makes a lot of sense. It's very common scenarios. So patient, for example, some patients were admitted because of COPD diagnosis initially, but point-of-care ultrasound found some changes in the cardiac exam. So ultimately, the patient was diagnosed with heart failure. Another patient was diagnosed with ascites due to liver disease, but ultimately by point-of-care ultrasound, we were diagnosed with DCM. Another patient was admitted for ACS rule-out, and then POCUS found features of cholecystitis. And then another example they gave is patient with anemia due to GI bleed found to have a mass on the hepatobiliary ultrasound. And of course, hypovolemia is a very challenging clinical encounter, and ultrasound can be very helpful. So, and then in another 24 patients, there's additional diagnosis in addition to the principal diagnosis made by point-of-care ultrasound. This is one really surprising, because a lot of prior studies actually showed that physicians who have more experience with ultrasound, they can also make some changes in the initial diagnosis and admission. But not surprisingly, the percentage is actually higher. It's almost 47 to 55% of admissions have either like additional diagnosis or they change the diagnosis because of point-of-care ultrasound. So what about medical students? Can they learn it, efficiently and make some changes too in their practice? So they had about 6 or 10 medical students, second-year medical students. They have the curriculum for point-of-care ultrasound in this medical school, and they had 4 physicians who had at least 10 and 20 years of clinical experience, and they have about 6 patients where they ask each participant, the second-year medical student and the physician, to do a liver span. So they asked the medical student to do it with ultrasound, and they asked the internal medicine physician to do it just by the bedside. And then the gold standard was a gastroenterologist who had experience in ultrasound to measure the liver span himself. So as you see here, these are the 6 patients. And then if you can see the maybe I should use a cursor here. So, all right. So these are the 6 patients, and the triangles are basically the average number of the liver span found by the experienced GI physician. And these are the, so we have 6 medical students, each examined each patient, so we have about 60 encounters. And this is the average liver span documented by them. And it's actually very close to the liver span made by the sonographer, the gastroenterologist. And as was shown by other studies, that bedside exam of liver span is really not very reliable. Even experienced physicians, they all underestimated the liver span by about 6 to 7 centimeters. So the medical students were able to accurately measure the liver span better than the experienced physician at the bedside. And I truly believe the bedside exam for liver span can be actually not really required, because it has shown a very limited likelihood ratios anyways. So what about the clinical use? There's procedural use ultrasound and non-procedural use ultrasound. I'm not really going to talk a lot about procedure. I think probably most of us agree that it's becoming almost like a standard of care now, for central lines, for paracentesis. And actually with paracentesis, one fun part about the POC is actually during the procedure, a lot of time when you're stuck with fluid, you don't know if it's really, there's no much fluid, or there's a bowel wall stuck in the catheter. You can actually do real life ultrasound, and you can actually see the bowel moving with your catheter if it's blocked by a bowel wall. So you can do some maneuvers to solve that problem, and instead of just canceling the procedure. So it's really fun to see that bowel moving with your catheter. And then the thoracentesis, it has shown a decrease of incidence of pneumothorax. You can actually use it as a landmark for your lumbar puncture for more accuracy, and then also for thoracentesis. Just one thing I really want to mention is we got consult for this patient for thoracentesis. So the resident was telling me, we get this consult, we need to rule it out. And I look at the X-ray, I was like, where's the effusion? So as you can see, there's blunting of the schizophrenic angles, but it's not it's not really that large. You can see it better in the lateral view, of course. But there's no way I could have done the thoracentesis without the ultrasound. Actually, Dr. Golobali, I don't know if she's here, she did that thoracentesis. She did a very good job. We found a very small pocket in the left side, and she did perfect. So the patient, I think, was discovered to have a malignancy. So in my old training, I had never done the routine way of percussion and do a thoracentesis in this patient with this small effusion without the ultrasound. All right, so small poll here. So I would like to kind of get an idea from the audience how many use point-of-care ultrasound as a clinical tool. So if you don't mind using your cell phone, and you can text, it's basically my first name and the first letters of my last name, and 724. It's not case sensitive. You can text it to this number, 37607. And then you'll get a text back that you joined the session. And I really want to know, if you, not really for procedure, but just for clinical diagnosis, have you used point-of-care ultrasound before or not? Whether you have used it quite often or sometimes or rarely or not at all. So, and again, this is for diagnosis, not really for procedures. All right. Like most of the audience has some experience with POCUS anyways. That's really good. And it's shifting a little bit now. Okay. So probably mostly some usage of POCUS. All right. See if I can. And then next, I would like to get another quick poll. Just activate it. I would like to know what clinical scenario you usually use point-of-care ultrasound for. So I will activate this one. And what I would suggest is you just type in just one or two words. And I will probably give you some suggestions for example, you use it for cardiac, lung, IVC, IJ, DVT, abdomen, renal, bladder, liver, gallbladder, so that we can know probably which one is the most commonly used. So IVC seems to be pattern. Cardiac also, abscess for sure. Abdomen exam. Okay. Any more? GYN. I'm not going to talk about that. Sorry. Infusions. So I kind of expected that probably IVC would be the most common, in addition to the cardiac, it looks like. Okay, very good. Thank you. So, as you probably know, there's really a lot of clinical applications for POCUS in internal medicine. I'm just going to touch base on these like really quick and show some studies that show its applicability. So for the IVC, probably one of the most common usage of POCUS, right? And there's like a wide range of usage for IVC. There have been a lot of studies done by ED, ICU. It has shown a lot of good numbers in patients who are ventilated. But again, I'm trying to focus here on the general internal medicine. For me, I usually use it for response of IV fluid, whether I'm not sure the patient needs fluid or not. Patient with heart failure and CVB estimation, if they have reasons to be dehydrated or they are overloaded. And then patient with tamponade. Also patient with AKI, renal failure, on dialysis, if you want to rule out hydronephrosis or you want to assess their volume status. And then also, which I don't think hasn't been studied that much, but I think it's potentially useful. We can actually do a lot of studies with point-of-care ultrasound for hyponatremia, I believe. It's the most common electrolyte abnormality that we see in the inpatient setting, and it's very challenging because volume status is really key in assessment of hyponatremia, but it's very difficult. So I think I tried to look up if there's any studies, but I haven't found much, to be honest with you. So I think it's potential area for studies to be done. There's two ways to get the IVC. The most common one is the subcostal, but you can get it through the liver to hepatic window. This patient is, I think this patient is a CRMC, just an example of a small IVC. As you can see here, it's small and collapsible. This is using one of our machines. This compared to this one. Also, I think also a heart failure patient in CRMC or the VA, I'm not too sure, but you see the full IVC here compared to the one before. Again, this is also using our device in CRMC here. And by the way, you can actually load the image directly from your device to your screen if you want, but it happened that I just took a video with my cell phone. So just some examples of some of the studies that have been done in general internal medicine. So they looked, this study published in the Journal of American JACC for looking at the prognostic value of IVC diameter and collapsibility in heart failure patients. So basically, they look at they divided the patient according to their IVC diameter. Patient who had a larger IVC diameter and smaller collapsibility, they were found to have a more events. I think they followed this patient for about a year and a half, compared to patient who has a smaller IVC diameter, and of course, much more than patient who do not have heart failure to begin with. And also they found that this patient has more likely to be older, more likely to have a lower BMI, more likely to have AFib, more likely to be on diuretics, which is not surprising, and they have larger left atrium volume. So it can be useful as a prognostic tool too. And in this one, also published in the same journal in 2008, it actually looked at the IVC and BMB to predict readmission after hospitalization, which is a very common problem nowadays. And what they found is basically it's the internal medicine resident are the operators, and they have like a 4-hour training in ultrasound and then at least 20 supervised images. So this is what considered by them as a limited ultrasound training. They don't have like years and years of experience. And then they have 75 patients admitted with acute heart failure. They followed them up for like 30 days. Rate of readmission was about 40%, which is about the average for a heart failure patient at that time. And they found that serum sodium, BMB, and IVC size and collapsibility were the only predictors that has statistical significance to predict readmission in 30 days. So actually it's very useful if you're about to discharge your patient. You can take their IVC if you're not sure if they're ready to go or not, and you're still debating whether they need to be continued on diuretics for 1 or 2 days. Here, in this study, it's done by the ED physicians. So they have a little bit more experience than us. And they looked into whether ultrasound can, of the IVC can predict a patient who's going to have like hypotension operatively if they give him propofol. So they have about 40 patients, non-emergent surgeries. Most of them are orthopedic surgeries. And they found that patient who had an IVC collapsibility index more than 50%, meaning it collapses more than 50%, and it's larger, it's smaller than 2 centimeters. They are more likely to get hypotension intraoperatively with propofol, and those who have less collapsibility, IVC bigger, they're less likely to get hypotension. And the sensitivity was 60%, specificity 75%, and odds ratio is about 7, so really good numbers there. These are relatively healthy patients. And then in this study, heading towards the kidney, it's a retrospective study. They look into the IVC, whether it could predict pre-renal versus renal AKI or kidney injury. So they basically, it's done in the ultrasound was done by internal medicine physicians who has some training in ultrasound. The number of patients was 36, relatively small to, as most of the studies that we have so far. And what they found is patients who have, again, IVC collapsibility higher, smaller IVC indicating probably hypovolemia. They're more likely to have a pre-renal AKI with a urine sodium less than 20, and those who had a larger, and also at the same time they have a FeNO less than 0.4, also indicating hypovolemia and pre-renal, possibly a pre-renal cause of their AKI. And then this is another interesting study for our nephrology colleagues. So I actually just learned recently that some of the nephrologists, they use ultrasound in their hemodialysis centers. So I don't know if this is one of the reasons, but they looked into the usefulness of IVC to kind of look at the volume status in their patient to see if they need a lot of volume removal versus not. So they looked into, they have 89 patients in 2 hemodialysis centers, and they did the ultrasound before dialysis and after dialysis, and also they did it if the patient had any symptoms during the session. And the ultrasound is actually done by medical resident too, and again, it was kind of very similar training, 4 hours of didactic training, and then they just go and do a lot of supervised imaging themselves. So what they found is patients with who have the hypovolemia by the IVC criteria, which is basically small IVC with large collapsibility, they had more episode of chest pain, cramping, and more episode of hypotension compared to those who did not meet the IVC criteria for hypovolemia. And also, actually, when they compared the 2 centers, the center who had a higher prevalence of pre-dialysis hypovolemia by IVC has also more significant intra-dialysis adverse events, meaning chest pain, cramps, symptoms that might suggest hypovolemia and probably over dialysis. All right, shifting gears a little bit for another use of POCUS is, I get a lot of questions from medical resident and medical student about physical exam of JVD, which could be challenging. So I was thinking, we do it for IVC, why don't we do it for IJ? So there has been studies looking into that. It's not very big, but again, they're actually very suggestive, and I personally found it really useful at the bedside in my practice. So this patient, I saw this patient in the VA a couple of months ago. He actually had classic JVD. You actually don't need ultrasound for that, but as you see, there's a wavy JVD here, all the way up to the earlobe. So I think he had pulmonary hypertension. He was admitted for volume overload, and was admitted for diuresis, basically. So what you look for in ultrasound is They call it the meniscus or like the taper. So you put the patient on 45 degree, right? So and then you use a high frequency probe. You look for the IJ, just like you do it when you want to put central line. And what you see on top of the JVD, you're looking for this tapering of the IJ. This is probably the point of where you can measure the JVD as an estimation of center pressure, if you want. So this is really what you look for. So in in our patient, he's actually I had to at 45 degree, he had the JVD all the way to the earlobe. So I had to have him set up like 90 degrees so that I can see the upper limit of his JVD. And after that, I did the ultrasound again, and finally I could get to the taper here, or the meniscus. So you see, it's kind of similar to the IVC. It's collapses with breathing, and you see this nice taper here. So obviously he had very high JVD even without ultrasound, but it kind of confirmed what I already know, but sometimes can be difficult for obese patients. So after a couple of days, he was diuresed, and you can see his JVD is not really that obvious like before. And when I did ultrasound again, this time I was able to get the taper a little bit in the mid of the neck, and he was actually about 45 or 60 degrees. So obviously his JVD went down after the diuresis. So I was kind of excited when I found that correlation. Again, DVT is also very common use. We all agree that ultrasound is very helpful here. It can be very useful if you need a quick answer. Just like one of my residents, Dr. White, I think he's here. Patient was having a code, and they found this clot in the exam of the DVT, but unfortunately the patient couldn't make it. And then also AAA exam, which could be very useful for our primary care physician colleagues. Actually, if you're comfortable with it, you can do it at the bedside in your office. And as you will see, you actually can bill for it. For lung, it had been used, a long time ago, and it's, data is very supportive of it. It has very good numbers in terms of sensitivity and specificity for different diagnoses like effusions, consolidation, pneumonia, and pneumothorax, which is actually one of the major uses of point-of-care ultrasound. So in this meta-analysis, they had 80 studies. The pool sensitivity for POCUS for pneumothorax was actually much higher than the chest X-ray, right? So it's more sensitive, that's for sure. It's more visually easy to recognize. And the specificity was actually very comparable. So just one example, I had this patient also in, this is actually a normal exam. Just play so what you look at in, is basically this nice sliding. This is a pleural line, this is a rib, this is a rib, this is a shed behind the rib. They call it the bag wing sign. And you see for a normal healthy patient, you see the nice sliding, the shimmering here, which indicates there's a well-aerated lung. So we had this patient in CRMC, actually 2 or 3 years ago. He underwent a biopsy. Unfortunately, he had pneumothorax, but it wasn't too bad. He just treated conservatively. And then after a few days, we did an X-ray. The X-ray was reported as normal, so like resolved pneumothorax. But we did a bedside ultrasound, and actually he still had the pneumothorax, but fortunately it wasn't clinically significant. So I don't know if Nitin is here. He's the one who got this picture. So I showed him how to do it in one of the lungs, and he actually did it in the abnormal lung, and he was able to get this image. Oops. He actually didn't have. He didn't do it before, but he was lucky. He get actually what's called the point. Or the transition point. It's basically, this is virtually diagnostic for pneumothorax, right? So if you see this, there's different causes for absent sliding, but if you see this junction here between sliding and non-sliding, this is virtually diagnostic, and you can see it also with the M mode, what they call the barcode sign. So Nitin was able to get it on the spot. And then we knew that the patient still had pneumothorax, but fortunately he didn't have to, it wasn't clinically significant. All right, so same for pneumonia. This is meta-analysis, included 5 studies. They also compared ultrasound to chest X-ray. It has a better sensitivity, 95% compared to 77%, and comparable specificity. For pneumonia can be a little bit challenging. There's different signs that you can look at. One of them is the B lines here. I actually had this patient also in CRMC. This is also using our handheld device. He was a HIV patient. He was admitted for pneumonia. The chest X-ray was reported as normal, but because the clinical suspicion was so high, he had a CT scan, and it confirmed that he had a left-sided consolidation. So I was curious to know if ultrasound would have picked that up. So this is the first one is his healthy, his normal or the the lung was without the pneumonia. He had, as you see here, he had nice sliding. There's no B lines. This is a pleural line. This is a positive sliding. And then this is the other side where he had the pneumonia. You know, this is a pleural line. You see it's very thick. You see a lot of vertical, hyperechoic, white shadows going all the way down, thick, kind of fulfilling the criteria for B lines. So this, you can get that with any type of edema, including, transudate from pneumonia. So it was very visually intuitive. So you know that it's only unilateral, so it's most likely suggestive of pneumonia. But there's other signs too that you can look for. All right. And then for B lines also, you can use it for heart failure. If you see it bilaterally in the upper lobes, it's almost always indicating pulmonary edema, whether it's cardiogenic or non-cardiogenic. So in this study, this prospective study, 60 patients, they excluded patients with lung disease so that it will not mask the finding. They look at the B lines at discharge, and they follow this patient over 3 months, and they look at mortality and rate of hospitalization. And patient who had like more than 30 lines, B lines, so like the one that we saw, they are more likely to be readmitted and have higher mortality than those who have fewer B lines, maybe indicating they have higher intravascular volume. And also, together with the NYHA class and BNB, it was associated with improved risk classification. So your patient, if they have a lot of B lines on discharge, they're classified as higher risk overall. This is just an example. So this is a patient admitted in CRMC also. You see he had that bilaterally. You see the pleural line, nice sliding, but you see a lot of B lines here. And this is after diuresis. So it's still a little bit thick pleural line, but no much B lines compared to this one. Still you can see a few of them, but it's not as much. So indicating that probably he was diuresed well. So this is a very nice article if you want to look into the lung ultrasound more closely. It tackles most of these diagnoses. For cardiac, a lot of uses, as you know, for POCUS for cardiac, it's really I think probably left ventricular contractility, effusion, tamponade are the major ones. But if you get more used to it, you can actually get more and more information. It's basically an echo if you really get yourself familiar with it. But generally, point of care cardiac is really for kind of a limited or specific question that you want to answer at the bedside. But again, it depends on your expertise. So they looked into whether internal medicine physician, not cardiologists, were able to pick up impaired left ventricular contraction by point of care ultrasound compared to a formal echo report. And what they found actually is a good correlation. So it was a prospective observational study. It's done in Minnesota, one academic center, 178 patients, and 10 internal medicine physicians who did the study. They just asked them to report it as normal contractility, mild or moderate decrease, or severe decrease in left ventricular contractility, and they compared that to the actual EF by the TTE. And it was found to have a high sensitivity of almost 90%, kind of a similar specificity, and the inter-rater agreement between the internal medicine physician and cardiologist and TTE was actually good with a kappa of 0.77. So I think they had few years experience, not really like much experience with ultrasound. So that kind of suggested that internists, if they want to learn it, they can actually have a comparable result to the formal TTE. So also another example that I had in CRMC, this patient was SLE, young female admitted with large effusion, heart failure, and tamponade. So the initial echo didn't report any features of echo tamponade. When I get to the service, she started to get a little bit tachycardic, more shortness of breath. CT surgery were consulted. They said, just continue the diuresis. But we get worried a little bit about her. So this is actually done by our big machine, not really the handheld one. And what we saw at the bedside is, of course, she had this large effusion, but she had compression of her right ventricular outflow tract. So we got worried about tamponade, and we ordered a repeat limited echo. And sure enough, the cardiologist called her that the patient is having features of tamponade and echo, and we consulted CT surgery again. They took her to OR. So it really made a lot of difference. For abdomen, it's a lot of use also. The common one being the hepatobiliary system, kidneys, hydronephrosis, urinary retention, confirming ascites, testicular disease. But actually, I found this one. This is kind of interesting. It's actually looking into whether ultrasound can pick up bowel edema and whether it can distinguish between inflammatory and non-inflammatory diarrhea in young female patient with abdominal pain and diarrhea. The ultrasonographer was a gastroenterologist who has some experience in ultrasound, but he wasn't like a radiologist. And they actually found that the sensitivity and the specificity of ultrasound for that is actually high, especially for the ileum, with a positive likelihood ratio of 36 and negative likelihood ratio of 2. And again, these were like young patient. They sent for ileum colostomy evaluation. We did ultrasound before that, and it was found to be relatively correlates well with the formal ileocoloscopy. For the musculoskeletal, I'm not going to talk about it. It's actually, there's a lot of data about it, actually a lot of guidelines. Dr. Yevyenko, I don't think she's here. She's actually trained in musculoskeletal sound. She can give a whole talk about that. It's well known, so it's very useful for a lot of arthritis patients. For neurology, apart from the LP that we talked about, if you do nerve block, you can do it with ultrasound. Patient with headache, temporal arthritis, you actually can have like have a halo sign. Yeah, sorry, go ahead.
You can also add diagnosis of intracranial occlusion and acute stroke.
Okay.
So one takes it to ED and one can do ultrasound and diagnose whether somebody needs a procedure.
Okay.
And if you change and look at it as a therapeutic module, you can actually agitate the clot, break down the clot, and reestablish perfusion.
There you go. Awesome. And actually, they do it a lot in the clinical ICU, neuro ICU too, for patients who had looking for vasospasm, non-invasively. So thank you very much. And then one other use that I found useful is patients with bowel edema. You can actually do globe ultrasound. It's most commonly used in trauma to look for like intraocular disease, but you can actually pick up edema really easily. So this is a globe. This is an optic nerve sheet. You can measure it. If it's, I think it's more than a specific number, it suggests bowel edema. You can actually, if it's really big, like stage 3 or 4, you can see a bulge here, like in this patient. Also, his patient of ours, you see this bulge here over the optic nerve sheath. So he was well known to have bowel edema bilaterally. I don't know if it was cocci or something else, but if you do the ultrasound, you can quite obviously visually see it here very easily. It takes like a few seconds. All right, so ID, it's at a lot of uses too. For sepsis in this study, they actually found that it's has a sensitivity of 73% and specificity of 95%. To pick up a cause of sepsis in the ED. They did cardiac, lung, abdomen, musculoskeletal, and skin and soft tissue. And the ED physicians were able to pick up a cause or a source for the sepsis. It took them only 10 minutes to do that. And the antibiotic was changed in 24% of these patients just because of the ultrasound usage. All right. Also, for abscess, is actually has very high sensitivity and specificity. It's one of the most common uses of ultrasound is to detect abscess in patients with cellulitis. And this is actually very interesting. It's a case report. It's a patient who was diagnosed because 50-something lady, diabetic, coming with right lower extremity cellulitis or skin infection in the dorsum of her foot. And the emergency physician did an ultrasound, and they saw features suggestive of necrotizing fasciitis. So they called CT surgery. CT said, well, get a CT scan first, and then we'll see afterwards. They did a CT scan. CT scan was reported as cellulitis with some edema. So they said, well, admit the patient antibiotic. We're not going to do anything. Patient was seen by ID because medicine were concerned. ID said, well, let's get an MRI. Maybe MRI will pick up something. MRI also was reported as cellulitis with some muscle edema. Patient get antibiotics only, no surgical intervention. On day 3, she got septic shock, and then they took her to OR, and they found necrotizing fasciitis on OR, was what they called a dirty dishwater finding during surgery, and the patient had to go to multiple surgeries afterwards. But ultimately, she was discharged for rehab after like a month or so. So again, it's a case report, but basically there are some features that you can see in ultrasound to suggest necrotizing fasciitis too. So this is kind of the normal finding. This is the skin. This is subcutaneous tissue. This is a fascia, and this is a muscle in normal healthy finding, and this is the abnormal finding. You see hyperechoic areas, whitish areas, could be like gas. There's some edema in the subcutaneous tissues. There's some air shadowing because of the air. This is of course if the patient has like a gas-forming organism. So what are some of the challenges? Equipment would be a major one. If you have a device, it's you get it. If you don't, then you have to think about how to get one. Time, it needs a little bit extra time to do the ultrasound, but again, it's just a few minutes really. So I don't really see it as it might be a challenge when you first get trained to it, but as you get more familiar with it, you get less and less time doing it. And then it's also for learning. If you start to learn others, again, there's a lot of resources that you can utilize. We're going to talk about that. And billings, a lot of people ask about billing. You can actually bill for it if you feel comfortable with documenting your finding in the chart. And we're going to talk about that too. So there's different equipment. This one is still called portable, but it's large. But we definitely have much lighter ones. This is a Clarius device. I tried to get one, but they told me you have to buy it first before you can try it. I was like, okay, I'm not going to do that. We already have 3 devices here in CRMC and one in the VA. This is the V-Scan. Very, very, very handy, very useful. I'm really looking into this one. So this one, I think they're going to release it in January. It's called the Butterfly IQ. It's actually connected to your iPhone. So it's FDA approved now. I think they're going to release it just next month. I think it's just for you have to be physician to get it. You have to, I think it's by prescription. So it's actually much cheaper because it uses a little bit different mechanisms, not like the traditional ultrasound. So they actually said it's less than $2,000 compared to the V-Scan, which is about $8,000, and this one, the Clarius, is about $6,000. So this one, I think, if it's turned to be like this, the way they advise it, it's going to be like really awesome device to use. So I'm really looking forward to try it if they have it in the market. I think probably in January. So look forward for it. And now they have point of call ultrasound training for almost any of the major meetings. ACB does it every year. Society of Hospital Medicine does it every year. And actually they have a certificate of completion if you want to. So they advise specific courses that you want to go to, that you have to go for. Mostly it's 1 day workshop. And then they ask you to file or create like online portfolio for your own images. They look at it. They have a specific number, then within 2 years, if you complete the number, then you get a certificate of completion. So there's a lot of movement that it's in the way of getting certifications and licensure. And then this is a very useful book if you really want to learn more about it. It's called Point of Care Ultrasound. They have a lot of images, videos, they have the online version of the book too. It's very useful. And the American Association of Medical, or the Association of for medical ultrasound. They have a very nice webinars and podcast for ultrasound. This is one of them, and they are free. There's a lot of other online resources, but this one is very useful. So they talked about billing, and they said there's specific criteria that you need to meet, but you actually can bill for it. So if you have your own ultrasound in your own office, there's two components. There's a professional component and there's a global component, which is kind of a device. So if you own the device, if you do it in your own office, you can bill both. You can get reimbursed for both. But if you work in a hospital, probably you're going to get reimbursed for only the professional part. But you need to have a separate note for your finding. There's some criteria that you need to meet. You need to write specifically the indication. What is it for? What's the medical necessity for the procedure? Describe the way you do the exam, and then you report your finding and your impression, and then the image has to be stored somewhere. So they have to access the image if they need to. So I think the movement of point-of-care ultrasound is really making a big stride. They're getting more and more certification, licensing. The devices are getting smaller and smaller, and they're just discovering more and more use of point-of-care ultrasound in different uses. And obviously, we move from the era of anatomy to just seeing the anatomy to the outside, and who knows, we might well have it all in our small devices. I think that's probably going to be the future. A lot of medical schools now, they have the curriculum for ultrasound, so you're going to see a lot of medical students already know a lot about it. And I think we need to have a curriculum for our resident here too. So in summary, again, I want to emphasize point-of-care ultrasound is not really a replacement for a good physical exam or bedside assessment. It's just a supplement to close the gap between your assessment and the formal images. You need to assess which part of ultrasound is useful for your practice, and you get trained on that and tailor it to your own use. And then think about how you're going to get the device. Again, if you get training, you're more comfortable with doing it. You can get billing, and you can calculate how much you will get out of it, and then you can pay your device if you want to buy one out of bucket. In the last meeting, the Society of Hospital Medicine was actually kind of surprised. A lot of my colleagues, a lot of hospitals, they actually bought the V-scan out of their bucket. They just found it very useful and convinced that they really want to buy it. So a lot of internists, they already have that device handy. And then, yes, you can bill for it. That's a really good part. And I think there's just a lot of more and more information coming out talking about it. So, thank you. And I didn't get there yet. I still see a lot of medical resident and student excited about the ultrasound. So I didn't have that phase, thank God. So thank you. Questions? Yeah.
There's obviously limited time, space in medical school residencies for additional training, right? You
Right.
have to squeeze in all kinds of stuff that they have to learn. Based on your expertise and your view of the literature, how many hours do residents need to just focus on residency to kind of get up to speed for point of care? I saw a few of your articles talk about 4 hours.
Right. I think it's.
Is there any amount of time that a residency program could devote to?
I think probably maybe you need to focus on specific areas that's more commonly used. I believe cardiac, lung, DVT, IVC, and IJ would be the way to start. I think a workshop for each of these with hands-on experience, so probably 2 or 3 workshops, I think should be a good start. And then we're thinking about actually creating like a portfolio for residents to be able to do their own images and then just upload the image to that website, and each resident maybe will have their own portfolio, and then physicians who have expertise in ultrasound, they can look at it, give them some feedback, and the more maybe we can specify a number that they need to reach to get quote unquote certification. I think that's very doable. I think probably we should move ahead and try. I'm currently working, trying to get a curriculum for that's how I look at it at this point. I don't know if Dr. Murphy has some ideas.
I want to agree with you and echo everything you said. We cannot overstress the importance of ultrasound and ultrasound education in 21st century physicians. Otherwise, we will be the gap generation because,
right.
As you said, medical students are getting trained, and this generation will go into practice with this gap in knowledge. Now, if there is one thing I disagree with you with, is it's easy to learn.
Okay.
It is not easy to learn, and it is very challenging. Now, most of the courses or curriculum are based on YouTube videos or industry-sponsored workshop, highly selected models. Then very easy to scan. Matter of fact, there was actually a pre-scanning to those models. I was trying to hire models, and I found out that they actually will bring 5 people, scan them, send 3 away, give them like a little bit money, and the ones who have good scan, because, well, this is what you expect from industry-sponsored courses. Having done that, I do this every day. I mean, there's no day that goes by that I don't scan someone by ultrasound or more, and probably the ones who work with me will see that. It is, you're trying to be the technician, the radiologist, and the clinician at the same time. The technician part is very hard, like getting those images, having the right angle, and also knowing the limitation. To scan one abnormal finding. So I find pleural effusion or pericardial effusion, and everyone gets excited and wants to scan this person. You need to have at least 3 normal exams for each abnormal one. Otherwise, you won't be comfortable. You will see that the band in the right ventricle, which is a normal finding, and you call it clot. I can't tell you how many times we got that. You will see something that is perfectly normal, and then you would call it abnormal. Now, the ultrasound is upside down, inside out. So it is different, counterintuitive to the anatomy that we have learned in medical school. So what I want to stress is you don't need consent to ultrasound anyone. I mean, you need just to tell us, the patient, that
right.
Even if you're doing a study, this is like no radiation. So grab the ultrasound and do it as part of your exam in normal people. And then you will get experience. We have ultrasound simulator here, and we're running ultrasound shops always with, like, for example, tomorrow, 7:30 with surgical critical care fellow, we have a workshop. We do it once a month, and it is open to everyone.
Yeah, I think probably the key here is really what I would encourage resident is a lot of time you already have your answers. You already had, for example, the echo report. I would just encourage you to go and do it. Although you already know what's going on, but I think it's very useful to kind of compare what you do at the bedside and challenge yourself with getting the image that they got in the formal echo, and then you just compare the result. Even if you have an answer, I think at the beginning you just grab the ultrasound, it's available there, go and see your patient, spend a couple of minutes doing it, and then do more and more, and then you'll feel more comfortable. I think then you will feel it's probably not very difficult, but again, yeah, at the beginning it's definitely challenging, but it's very doable, I'd probably say.
It's almost like since medical school, you've been using your stethoscope to listen to thousands and thousands of patients. Most of that's normal. And
right.
The point is you have to do a lot of normal ultrasounds to then appreciate the abnormal.
Yes, so seeing big blood clot in the femoral vein, and then
right.
having to rescan it, that's not what we want you to be able to do. We want you to be able to comfortably say, there is no blood clot here, because I collapsed all of those veins in 3 different points in each vein, and the likelihood of missing blood clot based on data is less than 1% now. So know your limitation, but know what we are looking for, what you are supposed to do. Right. And also, ultrasound is as if saying, I'm learning radiology. No, you will be learning one thing at a time, which is most relevant to your area of practice. So I will be learning 4 hours the IV collapsibility and probably the pneumothorax, and then next I will do some limited echocardiography, and more bedside checking for DVT has enormous implication in outpatient visit or in the hospital. So.
Sure. Thanks.